In 2021, 10 times more Americans died from opioid overdose death than in Iraq and Afghanistan combined. It's also been reported that enough fentanyl is flowing into this country right now to kill every single citizen. In Rhode Island, we're experiencing similar pain with 1 to 2 people dying every single day from opioid overdose death. These are sobering facts. Thankfully, we have dedicated members of our congressional delegation who understand the battle that we're up against and are providing real-world solutions. Senator Jack Reed is chairman of the Senate Arms Committee, is senior member of the Appropriations Committee, and brings a unique perspective to the opioid epidemic. I am so pleased to be joined by Senator Jack Reed to learn what is happening with our delegation in Congress and to learn more about what we can do about the opioid epidemic. So welcome, Senator.
Well, thank you very much, Linda. It's a pleasure to be here.
Senator Reed, as a senior member of the Appropriations Committee, which for our viewers is the largest and most powerful committee in the Senate that authors legislation to fund the federal government, why did you support the CARA bills, which are the Comprehensive Addiction and Recovery Acts, as well as the CARES Act?
Well, first, the CARA Act was the initial recognition that this is a comprehensive problem. You have to have not just medical care, but you have to have mental health care. You have to be able to counsel someone. You also have to understand their whole life, which means do they have affordable housing, adequate housing. So what CARA tried to do was provide comprehensive services, which was a major step forward. Before that, it was all piecemeal. You get some treatment, but you wouldn't get the total help you needed. Then the CARES Act came along and really streamlined a lot of the operations of CARA based on the experience we've had over the several years it was in effect. And so now you have much more of an emphasis on comprehensive care, which is absolutely the right approach to opioid addiction.
You're also instrumental in securing the congressionally directed funding for CODAC.
Yes.
And it's our new integrated care center in Providence, and it is all about comprehensive care. That's what we're doing. So why do you feel it's so important? Because you said it was important. Why do you feel it's so important to provide patients with fully integrated care?
Well, first about CODAC, I have a strong emotional attachment. The first headquarters, as you know, was on Pontiac Avenue in Cranston, about a 5-minute walk from my house. So CODAC is something I've known a long, long time. But working with Senator Whitehouse, I must commend him for his grit and determination. We were able to secure over $800,000 to the Comprehensive Care Center because it makes real this whole notion of CARA and comprehensive care. You have one facility, one site, where an individual can come and get medical treatment for an opioid problem, can get mental health counseling, can be treated for other illnesses that might be detected there, and also can get advice about social services that he or she might be available for. And as a result, you're talking about one stop. Now, the old model was you went to a place, you got your treatment for opioid addiction, and they said, well, if you have a problem with housing, go take a bus and go 2 bus rides over and go to that problem. People didn't do that. You've got the person there, you've got the comprehensive care, you're much better situated about treating the individual.
And we had talked the last time we were together about the massive depression and suicidality that we're experiencing now across the board, not just with folks for the opioid use disorder. And I really enjoyed that conversation because we are seeing it, and it's so important to be able to provide that care for people, because most people don't wake up one morning and say, you know, oh gee, I think I'm going to try opioids. You know, there's a lot of forces behind that decision to start to use. As you know, CODAC was the first in the nation to provide an opioid treatment program in both state and federal prisons. We're the first under the new regulations to put a mobile treatment unit on the road to really reach out to people who could not access medication-assisted treatment. We go right into directly underserved communities. We're also the first in the US to offer, as we've talked about, a full range of health, including primary care and wellness services to our patients. It's important to note that we are using a patient-centered whole health approach. So the family matters, and the individual, everything from the individual metabolism to the family, and the community. And that's going to be showcased in the new integrated healthcare center. Do you feel that this model could be a model for opioid treatment throughout the United States?
I think it should be the model because you're treating the whole person. And as you know better than anyone, addiction is not typically just a one-off thing. It's a combination of mental health issues, sometimes physical issues, environmental issues where the person is in such a desperate straits because of their housing situation or their family situation, they turn to that. So unless you have this comprehensive care, one, you're not effectively treating the patient, and two, you're wasting money. Let's be blunt about this. Sending someone hither and beyond to go get services, it costs more actually than dealing directly in a comprehensive way with the individual's problems. Someone is depressed and taking opioids. Well, treating the opioids might not help at all for the depression, but treating both could solve both problems in a much more effective way. So the irony here to some people is that this is not only the right thing to do, it's the smart thing to do economically.
I often hear there is also short-term and long-term repercussions to not treating comprehensively and competently. And very often funders aren't interested in long-term.
Right.
They want to see short-term.
Right.
And so, I really don't know how to address that with folks because, their own personal needs are important as well. So the short-term solutions are not usually the strongest solutions for these problems.
No, I mean, typically with people with addictions, there's frequent relapses. So yes, the opioid addiction was temporarily fixed. I mean, abstention from opioids for 6 months, 7 months, but then there's another crisis, mental health crisis or a physical crisis or just something else, and they're back on it. And in the long run, that gets more and more debilitating. And frankly, you end up spending a lot more money. I mean, one of the obvious things I point out is that, most people who have these problems and recognize them go to the emergency room. That's the most expensive form of care you can have. And it's not consistent, it's not continuous, it's a one-shot deal. But if you have a program like you're doing at CODAC, where the person is being treated comprehensively, they know where to go, they know they can get any help they need there, that's a much more efficient way to do it.
In 2021, U.S. overdose deaths surged to over 80,000, more than 10 times the number of U.S. military service members killed in post-9/11 wars in Iraq and Afghanistan, more than in the Vietnam War or the Korean War. As chairman of the Senate Armed Services Committee, what do you think is needed for us to combat this conflict within our borders?
Well, it's a very, again, a comprehensive approach must be taken. What I've tried to do in the Armed Services Committee is work with my other colleagues on other committees and incorporate in our National Defense Bill, which typically is the only or one of the few major pieces of legislation that passes, incorporate more funding for Homeland Security so they can better train their border agents, they can work better with their colleagues on the borders, more resources and authorities to the State Department to help train foreign police in terms of interdicting local drug dealers. And then, of course, the treatment. Just this year in our appropriations bill for opioid treatment, we have $5 billion, which if it's whole will be a $125 million increase. So these are the resources that get out to CODAC, get out to other people, which is so critical. So we're trying to treat, we're trying to interrupt through law enforcement the movement of these drugs. And we've also working with my colleagues on the banking committee, I also sit on the banking committee, we sponsored legislation that's going after the money of the people behind this. The producers of fentanyl in China, the narco conglomerates that bring the fentanyl in, then mix it together and then try to get it across the border. We're sanctioning them when we find them, and we're trying to use economic pressure to disrupt their whole entire operation. So it is a comprehensive approach from law enforcement to healthcare, to financial sanctions, to diplomacy. All of that has to be used.
And we're going to talk just a little bit about fentanyl here, and
Yes,
you just talked about it. So last year, the DEA seized enough fentanyl, as we said before, again, to kill every American. More than 50 million fentanyl-laced pills and over 10,000 pounds of fentanyl powder. As a member of the Select Committee on Intelligence, what more needs to be done to protect our citizens from this?
Well, I think, we have to really take the fight overseas as the source of the problem. That's why, as I indicated before, we've passed legislation that is going to target those producers of fentanyl overseas, those traders in fentanyl, and also the narco gangs that are taking the money and take the fentanyl rather, and converting it into other types of drugs, mixing with drugs, etc. We want that to happen. Then we want also to be able to work closely with local governments to regulate and to disrupt the trade in drugs, any type of drug. But fentanyl now is a key one. And that's State Department working closely with local governments to provide the type of training. We want to strengthen our border, more resources for our customs and our agents across the way. So we're trying to go a across-the-board strategy, disrupt the source of supply, interrupt the intermediaries that are getting the fentanyl, mixing, et cetera, and then prevent it from being delivered into the United States. And then, of course, we're working obviously with local police departments and law enforcement agencies to provide them the evidence, information, et cetera, so that they can crack down locally. And it's an all-out battle.
I would like to ask you one more question.
Sure.
What I have heard, what we've read, is that the majority of the fentanyl originates in factories in China.
Mm-hmm.
And when you're talking about looking to the source, could you share with me how that would happen? I don't understand how that could happen.
No, here's what happens is basically you have a series of intermediary companies. Some of them created, some maybe here in the United States, they're created in third countries. So what they do is they ship it to the third country. This shipper will then pass it on. Some of it's smuggled in. The vast majority is smuggled in, but in places like Mexico, the smuggling or the movement is easier than in the United States. And so that's where you find a lot of these narco organizations taking the fentanyl, mixing it with cocaine, for example, then shipping it across the border, smuggling it really, as cocaine. But then, unfortunately, many people take it thinking it's simply cocaine, and it's a fatal dose. So But what has been happened is that these companies overseas are very clever about disguising the shipments through multiple different parties that they've created. So we're constantly on a race to track them down. And when we get close many times, that company vanishes and a new company, which is sometimes only a mailbox, it's not a real company, is created. And now we have to look and gather evidence about, well, what is this company doing? What laws are they violating, et cetera. And that goes for the difficulty of imposing sanctions on any entity for any product throughout the world.
Well, that answered my question. Thank you very much.
Surely.
Is there anything else you'd like to add or
Well, I
talk
want
to
to
us
commend
about?
the CODAC for just being a leader and going back many, many years in terms of dealing with the problem of drug abuse, particularly in embracing the notion of a comprehensive approach to opioid addiction, any type of addiction. I think you're leading the way. I think it's a national model. I think that's why when Senator Whitehouse and I were working to get the funds, we were able to make a very persuasive argument to our colleagues that this is the future. The comprehensive care, from primary care to mental health care to direct treatment of an addiction, this is the way to go. So I just want to thank you and CODAC and all the wonderful people you have working with you. They really make the difference. And this is the problem that we're going to beat, but we're not going to beat it without CODAC.
Thank you very, very
Sure.
much. And thank you for being here.
Thank you.
Thank you.
Thank you so much.
From Rhode Island's recovery leader, CODAC's mobile unit is on our streets. Our state's vulnerable populations now have access to more medical resources to better foster recovery through treatment. Leading our state's battle against opioid use disorder, CODAC is addressing the social determinants of healthcare by providing mobile medical services to communities most in need. To learn when and where CODAC's mobile unit will be in your community, visit CODACinc.org.
Here in Rhode Island, we are remarkably fortunate to have such accomplished senators in Washington, D.C. working for us. I also had the opportunity to sit down with Senator Sheldon Whitehouse. You've not only been a tremendous partner for CODAC, but you've been a tremendous advocate nationally. Can you describe to us a little bit of your history from when you were in the Attorney General's office to wherever else you have gone in terms of your understanding of the disease that we treat?
Well, I think I started working with you in the advocacy community back when I was working for Governor Sondland. And we were putting budgets together and working on legislation. But the first really notable move I was able to make was when I was elected Attorney General and was able to shift the position of the Attorney General's office from opposing a drug court to enthusiastically supporting a drug court. And with that, the drug court was launched with a lot of support from Judge Rogers.
Yes.
Joe Rogers then, the chief of the Superior Court, and the various judges who've supported it since then. So I got an early start back then, understanding that there are better ways to deal with addiction and recovery than prosecution and incarceration.
Yes. And it's interesting to me that we don't have to say that as many times now as we did then, but we still have to say it.
Yeah, it's still, unfortunately, it still needs to be said. But anybody who has been to a drug court graduation, as opposed to a criminal sentencing, it's an unforgettable difference. A drug court takes the power, as you know, of the judiciary, and instead of using it to convict and incarcerate an individual, uses it to set guardrails for a pathway for them to recovery. If they fall off the pathway, they've got to come back to the court and explain themselves. If they persistently fall, well, then they may go back to the original prosecution and incarceration mode. But at least it gives a very strong, powerful exit ramp for people to get into the treatment that they need and avoid the burden on the prisons and the law enforcement side.
And at this point, this is truly evidence-based.
Oh, yeah.
What was initiated is proven to work, proven.
Yeah.
Yeah.
We had good support from Brown and others with the support for the concept initially, but nothing actually succeeds like actual success. And the record of the drug court is phenomenal, and it's now expanded so that there's a mental health court.
Would you like to tell us a little bit about the Comprehensive Addiction and Recovery Act?
Sure. This was the first major bill I worked on in Congress on addiction and recovery. I knew it had to be bipartisan, so I worked with a Republican colleague, Rob Portman, who is from Ohio, which had a terrible footprint of overdoses, a little bit like ours. And so we had common cause there. And then we put a lot of work into preparing the law with national conferences that we brought people in from the health sector, from the law enforcement sector, from recovery programs, and to make sure that we had a really robust bill and a lot of advocacy support for it. And so at the end of the day, when we filed and pushed it forward, it got a very good reception. This was such an obviously needed measure that we were able to blow through those hesitancies and get the bill passed with a very strong bipartisan vote in the Senate. And then with it done in the Senate, it was short work in the House to get it passed into law.
So CARA 2.0, can you tell us a little bit about?
Well, CARA 2.0 sort of followed up on CARA with money. So CARA was the authorizing bill that allowed a whole bunch of programs to be started. Most significantly, for the first time, it put congressional interest behind the recovery part of the process. So it was a very big deal, but it really matters a lot when the actual money comes through. And CARA 2.0 brought in, I want to say, $750 million. Yeah.
Moving forward, Senator, what do you see as the biggest barrier to providers, well, to all of us as we work as a team, turning the tide on this epidemic?
Well, I think there's still some lingering instinct towards punishment rather than treatment, although much less. I think that there is still considerable lingering stigma, although again, much less. And then there's a major resource issue with supporting the people who do the work of providing the treatment and the care for people who are getting out of addiction and through recovery.
Well, I agree with that. We have a tremendous workforce issue, tremendous. And so across the nation, but here in particular in Rhode Island, we have individuals who have been with an entity, say, for 20 years or 30 years even. There is a piece of compensation that is, I think, reflective of the historic stigma. We are overregulated and undercompensated due to basically institutionalized stigma. And so Rhode Island has the fourth lowest rate in the country for Medicaid treating these diseases, but we have the 8th highest rate of per capita overdose death. And so it's very difficult for me as a provider to be able to reconcile those two things. Yeah. It's very difficult. Can you see any way that would help us reconcile that? Because it's a huge disparity, and it flavors every single thing that we do all day long.
Well, the CARA money coming in has supported groups and allowed them to get additional resources, so that has been helpful. I think Medicaid reform in Rhode Island is a work in progress, but progress will be signaled by better compensation for mental health, behavioral health, and addiction work. I think the backstory here is actually quite a good one, and that is that the people who come to this work come to it out of a feeling of love and mission and passion and are willing to be underpaid. But that doesn't mean that it's fair that they should be
And it
underpaid.
doesn't hold.
And it doesn't hold over time.
No,
Exactly.
because I need a home, I want children, I want to pay off my student loan. Senator, how do you believe that we could educate general population across the board, across the country, but in particular here in Rhode Island, better educate people around what is this disease, what is the epidemic? And we have been struggling for decades to get that information out there. How would you see us perhaps changing, becoming more effective with the messaging we're doing?
Every person who recognizes their addiction, moves into recovery and rebuilds their lives has enormous impact on all the people around them who see that transformation. And I think when you see treatment and recovery working, that's the strongest message of all, because it comes through to the people who are the loved ones and the kin and the friends of the individual involved, and it's very meaningful when it's someone you know, when it's someone you love. You can't beat that. So making sure the resources are there, making sure the programs are there, making sure the successes are there, I think is our very best strategy.
I think from the very beginning, both Michael and I, the board of CODAC, the senior leadership and councils of CODAC, all agreed that the individuals that were coming through the door deserved a level of treatment that would prove to significantly improve their lives forever.
We always felt that the drug part was just the tip of an iceberg. Every time CODAC did something new, it was because there wasn't something there before. CODAC was the first not only to be a general outpatient program, but the first intensive outpatient program and the first day treatment program in Rhode Island.
That behavioral health part of having a counselor is definitely needed with the medication. My counselor has become my best friend. She's pushed me in the right direction. She's told me when I was wrong. I almost didn't go. I really almost did not go to treatment. And I wonder today where I would be if I didn't.
The mission of CODAC is providing the comprehensive care that is needed by those that come to us for our services for them to enjoy recovery. As we have grown, as we have realized the intersection of science and service, we have been able to provide more and more care for those that have opioid use disorder. We began providing psychiatric care. We began providing specialty medicine care. And then as we've moved on and evolved through the leadership of Craig Stenning, then through Mike Rizzi, we continued to add services that reflected the needs demonstrated when someone came in for care. Now we provide primary care and we provide specialty medicine in the form of a full infectious disease program. We provide psychiatric care and mental health care, and we also have what is called OTP, Opioid Treatment Program Health Home. Childcare, transportation, all those different external, so to speak, issues that people face that get in the way of them being healthy.
We saw substance use treatment as a professional part of the medical community. To the credit of CODAC, it didn't go away after 10 years or after 20 years or after 30 years, and here we are after 50 years. I can proudly say that I'm thrilled with where CODAC is today and where it will be in the next 50 years.
CODAC Healthcare today does what we refer to as fully integrated healthcare. Of course, we treat opioid use disorder and other substance use disorders. We do it with therapy, we do it with medicines. We provide primary care now. We provide psychiatric and mental health care. And as we move into our larger facilities with more capacity, we're going to also be able to provide all the social service networks in order to get their basic needs met.